Everybody, we're going to get started now. My name is Rachel Rennick, and I work for the NYU Cancer Institute in the Community Outreach and Education Department. I would like to welcome everyone to today's Skin Cancer Awareness Program. This is an annual program in recognition of National Melanoma and Skin Cancer Detection and Prevention Month. We would especially like to thank the Molly Begain Melanoma Foundation for co-sponsoring this program with us. Their mission is to increase awareness for the prevention of melanoma, to provide information and services on skin cancer detection, and to support melanoma patients through education regarding the latest treatments. I would like to thank Maggie and Jack Begain, who are here today, for your continued support on this program. We always love having you here. And they are also going to be doing a taxi cab PSA, which is to raise awareness about skin cancer. They are going to be featured in cabs in New York City, Miami, Chicago, Boston, and LA, and it's a great way to raise awareness.
Okay, thank you for inviting me back to speak. I really look forward to this program here every year at NYU because I feel very passionate about skin cancer. I think people underestimate the impact that it has on our society because it really is the most common cancer and also one of the most preventable and curable when it's caught early. So I'm hoping I can enlighten you as to how we can be better aware and how we might be able to diagnose these skin cancers even better. Okay, so skin cancer is the most common form of cancer in the United States, and it's actually more common than new cases of breast cancer, prostate cancer, lung cancer, and colon cancer combined. So it's really very, very common. Substantially more than 1 million new cases of skin cancer will be diagnosed this year alone in the United States, and that's because many skin cancers are treated in outpatient dermatologist offices and never reported. So the actual number is actually far greater than the 1 million number that you hear thrown around. It's thought that this year alone, greater than 11,000 people will die from skin cancer, and about 75% of those will be from malignant melanoma, which is the most serious form of skin cancer. It's thought that 1 in 5 Americans will develop some form of skin cancer at some point in their lifetime, and this actually includes patients with darker skin, like Asian Americans, African Americans. So when you're looking at someone with lighter skin who's had significant sun exposure, it's actually far more likely than 1 in 5, which is very high. The most common types of skin cancer, which I will be talking about today, are basal cell carcinoma, squamous cell carcinoma, and malignant melanoma. And as I mentioned, even though melanoma is the rarest of these three, accounting for only about 4% of newly diagnosed skin cancers, it does account for 75% of deaths from skin cancer. So this is really the most serious type, and my colleagues later will be enlightening you more about that as well. So skin cancer includes a variety of types of cancers, melanoma, which is the big one we'll be talking about today, as well as a whole subgroup called non-melanoma skin cancers, the most common of which are basal and squamous cell carcinoma. The others on this list are things that maybe I see once or twice a year, so I'm not going to focus on them in this talk. So as far as new cases of skin cancer, about 80% of them are basal cell carcinoma, making that the most common diagnosed cancer in the United States. About 16% are squamous cell carcinoma, and then a small percentage, 4% being melanoma. But again, because melanoma is the one that has potential to spread through the body, it is very important to learn about this so we can detect them early and try to treat them before they spread. I'll first talk about non-melanoma skin cancers, again focusing on basal and squamous cell carcinoma because they are so common, representing half of all cancers diagnosed in this country. So for basal and squamous cell cancer, it's thought that about half of all Americans who live to age 65 will have one of these types of cancers at least once. There is a large cost associated with treating these cancers in our country. And fortunately, although they're very common, basal and squamous cell carcinoma are not usually life-threatening. The mortality is only on the order of about 1 to 2%, with most of those being metastatic squamous cell cancer. So it's reassuring because basal cell cancer is by far the most common, but also the least aggressive. So I usually tell patients, more than 1 in 5 Americans will develop this, but luckily they're completely curable. We treat them because they can be locally disfiguring, but basal and squamous cell have a very low chance of spreading throughout the body. So we'll start with the most common, which is basal cell carcinoma. About 80% of all skin cancers, again, the most common skin malignancy and also the most common malignancy overall. Fortunately, as I mentioned, this has a very low risk of ever metastasizing. They usually stay local in the skin and grow locally, and far less than 1% of these ever spread anywhere outside of the skin. However, once an individual has one basal cell carcinoma, they have about a 40% chance of developing another one within 5 years. So once somebody has had skin cancer, we check them even more regularly because they're at risk for future basal cells as well as squamous cell and melanoma as well. And also, we used to think that basal and squamous cell cancers only occurred in older people who spent a lot of time in the sun, but I'm diagnosing people every week in my office. It's thought that the number of women under age 40 has more than doubled in the last 30 years. So this is really basal cell carcinoma we can see in women and men as young as 20s and 30s sometimes. They're becoming very common. I'd like to talk a little bit about the risk factors for development of non-melanoma skin cancer. We think of people with fair skin, light eyes, light hair, a family history, extensive sun exposure, and an outdoor profession. And you'll find a little bit later when I talk about the epidemiology for melanoma, there are some individual risk factors for that which are separate from this, but certainly basal cell and squamous cell carcinoma are far more common in people with light skin, light hair who spend a lot of time outdoors, although we're seeing increasing numbers in darker skin patients as well. So what do these look like? The classic basal cell carcinoma, we talk about a pearly papule because they often have this sort of shiny border. The border is often rolled, and sometimes there's a crusted central indentation or an erosion. And as the growth enlarges, we sometimes see tiny blood vessels, which we call telangiectasias, developing on the surface. Also, though, basal cell carcinoma sometimes can be more subtle, like the pimple that doesn't go away or the cut that doesn't heal. So any sort of open sore that's lingering, bleeding, crusting, this can be a sign of an early basal cell carcinoma and should be biopsied to determine whether or not this is a skin cancer. I very often see men who come in and they say they have a shaving cut that's not healing, or again, the pimple that doesn't go away. So these can be signs of early basal cell cancer. In darker skin patients, and as I mentioned, we're seeing more of these in darker skin patients as well, they sometimes can look like a regular mole, but they tend to have the same shiny kind of pearly appearance. They can be skin colored, pink, red, white, or pigmented when they occur in darker skin patients. There's a rarer variant of basal cell carcinoma, which is called morpheaform, which means scar-like. Sometimes we see a scar in a patient, and the patient denies any previous biopsy or any previous trauma to the area. So this type of basal cell cancer is much more rare, but it actually can be a more aggressive type. So if someone has a scar appearing on their body, especially on a sun-exposed area, but don't recall any prior trauma, that should be biopsied as well to rule out the possibility. I'll now talk about squamous cell carcinoma, which is the second most common type of skin cancer. Again, compared to melanoma, squamous cell is not as aggressive, but I think of squamous cell carcinoma as somewhere in the middle. So it's more aggressive than basal cell cancer, less aggressive than melanoma, but it does have potential to metastasize if it's not treated. And there are certain locations. Squamous cell cancer is correlated to chronic sun exposure. So there are areas like the scalp, the ears, the back of the hands that are very common, the lower lip. These are areas that are exposed year-round, not just in the summertime, and we tend to get squamous cell cancers in these locations. Similar risk factors to basal cell carcinoma, but again, this is the one that's most correlated with extensive cumulative sun exposure. So we often see squamous cell cancers in people that might have jobs outside, that spend a lot of time over the years outside in the sun, and the incidence definitely increases with age. Again, many of these occur in sun-exposed areas like the upper limbs, the head, the neck, very common in people with light skin, light eyes, light hair, maybe people who work outside. And then there are probably many people in this audience that have been diagnosed with actinic keratoses. These are precancerous lesions, and they're incredibly common. In fact, they're the most frequent reason that people visit a dermatologist. These are considered precursor lesions to squamous cell cancer, and they account for about 10% of dermatologist visits. I'll show you some pictures of actinic keratoses as well as squamous cell carcinoma, but the presence of actinic keratoses does identify patients who've had a lot of sun exposure and who are high risk for developing other skin cancers. It's thought that about 8% of each individual actinic keratosis lesion can progress to become a squamous cell cancer. So same risk factors really as squamous cell cancer. We see AKs and squamous cells in people that have light skin, who've spent a lot of time outdoors, and these occur almost exclusively on sun-exposed areas. So how do these look? What's interesting about AKs, or actinic keratoses, is that you often don't really see them. It's often a feel. So usually when I check someone's body in the office, I wear gloves for most of the examination, and then I'll take the gloves off and feel areas like the forehead, the scalp, the ears, the back of the hands. Again, areas that are exposed on a daily basis to sun. And they're sometimes subtle, these thin, scaly patches. Oftentimes they're confluent, so a whole area might be involved, and we sometimes treat a whole field to get rid of these. As I mentioned, they're very common on areas that are exposed to the sun every day. So again, our covered areas might only be exposed in the summertime, but when we walk around New York City, our ears, our scalps, especially in men, our lips are exposed every day, which is why we really want to think about sun protection as part of our daily routine, but these are very common areas to get these lesions. One other additional risk factor for squamous cell cancer, in addition to working outside, spending time outside, light skin, there's a subset of squamous cell cancer that can occur in covered areas that maybe where the skin was damaged by either a burn, sometimes a wart can turn into squamous cell cancer, an open sore, or exposure to radiation and certain chemicals like arsenic. So there are some other factors other than the sun that might contribute to the development of squamous cell carcinoma. So these look a little different than basal cell, which I spoke about earlier. Squamous cell carcinoma characteristically is very scaly. So the outside layer of the skin, the epidermis, is turning over so rapidly that you often see what we call hyperkeratosis, or thickened keratin on the surface of the skin. So these thick, rough, scaly patches. But again, they sometimes can be more subtle, like the patch of dry skin that doesn't go away or the scab that doesn't heal. Again, these things might indicate the need for a biopsy. Again, they can look kind of warty, commonly occurring on the ears, the lower lips. Squamous cell cancer of the lower lip can be more aggressive, and this is a very common subtype, especially in smokers, because smoking poses an additional risk factor in this area. So areas like the lip, the ear, have a slightly higher chance for metastasis. We really want to make sure that we get rid of these before they spread and cause problems. Again, an open sore that bleeds and crusts that persist needs a biopsy. This is an unusual variant, but something called subungual squamous cell carcinoma. It occurs under the fingernail. Oftentimes, this is diagnosed very late, so this has a slightly higher chance of spreading as well. And luckily, we generally diagnose and treat these very early, but we can see neglected squamous cell or basal cell. Oftentimes, patients think, well, as long as it's not melanoma, why do I need to treat it? It's not going to spread. It's not going to kill me. But they can grow out of control. They can cause infections, abscesses. So, again, we like to treat these as dermatologists while they're localized to the skin and while they're small and easy to remove. Fortunately, both basal and squamous cell cancer have a better than 95% cure rate when they're detected and treated early. I'm not going into detail here in this talk. My training is in Mohs micrographic surgery, which is a specialized technique to treat non-melanoma skin cancer, where we try to remove as little normal skin as possible and get rid of the cancer, but that's sort of outside the scope of this discussion. So I'll conclude with talking about malignant melanoma before I turn the talks over to my colleagues. But melanoma is really the most serious type of skin cancer because if it's not caught early, it does have potential to metastasize. And there's really such a dichotomy. When we catch these early, it's very satisfying. We cut them out under local anesthesia in an outpatient dermatologist office. Once the melanoma becomes thicker and has potential to involve lymph nodes and other parts of the body, which you'll hear about from Dr. Berman and Dr. Pavlik, it then becomes a problem that needs to be handled in the hospital, and it can have much more serious consequence. So I'm hoping to sort of enlighten you about how common this is and how key it is to really increase awareness so we can get better at diagnosing and treating these early. Melanoma is rising at a rate faster than any other type of cancer, with a almost 700% increase over the past 50 years. Part of this is because we're getting better at diagnosing them, but part of it is a true increase in incidence. So it's thought that back in the 1930s, about 1 in 2,500 Americans developed melanoma. This year, the risk is projected to be 1 in 58, so huge increase. Last year, there were over 120,000 new cases of malignant melanoma, making it the 6th most common cancer diagnosed in the United States in both men and women. So in addition to some of the risk factors we talked about with non-melanoma skin cancer, namely light skin, light eyes, There are risk factors that really make melanoma unique that we should talk about. What's interesting is, unlike non-melanoma skin cancer, which we often see in patients after years and years of chronic sun exposure, for melanoma, we think of people who are sunbursters, so people that maybe got short, intense bursts of sunlight at some point while they were growing up. Maybe people who live in places like New York and go get a blistering sunburn in the Caribbean once a year. You know, that's a separate risk factor for developing melanoma. So it's thought that 5 sunburns at any age in your life can double your risk of developing melanoma. But even 1 blistering sunburn during childhood and adolescence doubles your risk for melanoma later in life as well. So it's really important that we educate children while they're younger. We tell them to stay away from tanning salons, which I'll talk about, because it's really important that people realize that some of the damage they get during childhood and adolescence can manifest later in life with serious melanoma. It's thought in this country that 1 person dies from melanoma every hour. And another thing, there's a subset of young women which are at very high risk for developing this disease. It is the leading cause of cancer-related death in young women. After about age 40, 45, the trend actually crosses over, and then it becomes more common in men. So actually, older males, like after about age 50, 60, they have the highest mortality. So it's very common, and it can be very serious in young women. And then the next population that's at greatest risk is older Caucasian males. But the good news is that if we catch these early, melanoma does have a 99% 5-year survival if we can detect them and treat them before they gain access to the blood vessels and lymph nodes and before they spread. So some of the risk factors are the same, as I mentioned. There is an increased risk for patients with light skin, light hair, light eyes. Having a personal or family history of melanoma is actually the most important risk factor. But then there are a couple other risk factors which are unique to melanoma. Having a lot of atypical moles, which I'll show you a picture of, but people that have numerous dysplastic nevi or atypical moles are at risk for developing melanoma both in those moles, because the moles can turn into melanoma, but also in their normal skin. And then, as I mentioned, this intermittent, intense sun exposure. So people that maybe don't work outside, they work inside, but they get a week or 2 of really intense sun sometime throughout their year. Sun tanning devices, there's a lot of interest in this area now and a lot of movement to try and ban the use of tanning salons in minors because it has been recognized as a carcinogen, just like smoking. We know that even 1 exposure to a tanning bed during youth and adolescence can increase your risk for melanoma by 75%, so that's huge. And also, tanning salons increase your risk for squamous and basal cell carcinoma as well. These are the dysplastic nevi, or atypical moles I talked about. As I mentioned, these patients have an increased risk of developing melanoma both within the moles, but also in their normal skin. So I see these patients very regularly in my practice. The key is really diagnosing these early. Dr. Berman's going to talk about surgical management of more advanced melanomas in a couple minutes, but the prognosis for melanoma is directly proportional to the thickness. So the thinner and the earlier that we can catch these, the better chance we have for curing them with a very good survival rate when tumors are diagnosed less than 0.76 millimeters, and that really drops precipitously once the melanoma starts to invade down into the skin and gaining access to blood vessels and lymphatics. So the ABCDEs is a way, it's an acronym we can think of diagnosing melanoma. Asymmetry is suggesting that melanomas are often asymmetrical. So when you look at a benign mole, they're usually very even. You can sort of fold them in half, and one side might mirror the other half exactly. But melanoma often has an asymmetry to it. B is for border irregularity. So again, benign moles are often very smooth and evenly bordered. But if you look at melanomas, sometimes the borders are jagged or scalloped or notched. C is color variability. Again, there are some exceptions to these rules, but most benign moles are very evenly colored. They might be evenly tan, light brown, dark brown. But if you start to see areas of different shades or even black, sometimes white or red, those can be sort of ominous signs that this mole is turning towards melanoma. So certainly they should be biopsied. D is for diameter, and this one's a little controversial because luckily we've gotten so much better at diagnosing melanomas, so we no longer use 6 millimeters as our cutoff. Fortunately, we're diagnosing melanomas now at 3-4 millimeters in diameter, but it's still part of the acronym because it is true that melanomas do tend to grow larger, so if we don't catch them early necessarily, anything that's expanding rapidly should be biopsied because these could be melanomas. And E is for evolution. This was most recently added just a few years ago, actually, here at NYU. NYU doctors came up with this whole acronym. But evolution is probably the most important for, yes? Sorry? Oh, okay. So the A, B, C, Ds have been around since the 1970s, and the E was just added within the past several years, really to enlighten people and doctors as well that change is the most important. So if I follow somebody with atypical moles and I notice a recent change, right away that should be evaluated and biopsied because it could mean that something is turning into melanoma. Just a few subtypes that are worth mentioning. African Americans tend to get melanomas in different locations, like the soles of their feet, sometimes in the mucosa of their mouth. It's thought maybe there's less melanin in these areas, so they tend to get melanomas at a higher frequency in these unusual locations, and they tend to be diagnosed a little bit later. There's one type of melanoma that doesn't obey the ABCDs because they tend to be sometimes very round, smooth, symmetrical. But anytime you see black in the skin or a new black nodule, this can be an aggressive type of melanoma that grows very quickly. So certainly those should be biopsied. And these are pictures of more advanced melanomas. Another unusual type, but you can get melanoma of the nail plate or the nail fold. This can be also diagnosed later because people tend to ignore it. So if you see new streaks in your fingernails, that should be evaluated as well. Okay, so I'm going to wait and let Dr. Berman talk about surgical management of melanoma, but suffice it to say that we want to diagnose these early while they are still treatable. So just a brief word on sunscreens. The American Academy of Dermatology suggests that regardless of your skin type, you should wear a daily SPF of at least 30 year-round, again, not just in the summertime, but every day. And it's thought that daily use can prevent development of both melanoma and non-melanoma skin cancer, as well as premature aging of the skin. We do think that up to 90% of skin cancers are associated with exposure to ultraviolet radiation from the sun. And interestingly, up to 90% of just visible changes that we associate with aging are also caused by the sun. Sometimes I tell patients that if the risk of skin cancer isn't enough to scare you, your vanity should, because if you wear sunscreen every day, you'll have less undesirable sunspots, fine lines, wrinkles. Again, about 90% of photoaging is caused by ultraviolet radiation. Just some more pictures of very common sun-exposed areas. So even on a cloudy day, I put sunscreen on even when it's raining. Up to 80% of ultraviolet rays can pass through the clouds. Ultraviolet A rays can pass through office windows, car windows. Sun is very reflective, so people think of it when they go to the beach, but if you compare reflection on sand versus snow, there's a much higher reflective power of sun on snow, so skiers should really be careful. And again, 5 or more sunburns doubles your risk for developing skin cancer, so you really should get in the habit of making sunscreen part of your routine. Contrary to popular belief, only about 25% of a person's lifetime sun exposure is acquired before age 18. Every day I hear many people say to me, oh, it's too late, the damage is already done, I don't go in the sun now, I did it when I was younger. But the sun continues to age, and certain types of skin cancer, like squamous cell cancer and basal cell, are really a product of cumulative sun exposure, so it's not too late to start protecting yourself. You should apply sunscreen ideally to dry skin before going outdoors. People often use a little drop and think that's good for the day, but really you should use the equivalent of a full shot glass to cover your exposed areas. And also you want to remember to reapply at least every 2 hours, and more frequently if you're swimming or if you're perspiring. So what can you do? After hearing about how common skin cancer is, what can you do to minimize your risks? Number one, you want to try to avoid peak hours of sunlight. And I know that's a large window, 10 to 4, but as best as possible, you want to avoid the strongest sun's rays during those hours. You want to use a daily sunscreen of SPF 30 or higher. You want to wear protective clothing. I see a lot of young women who say that they put sunscreen on, but they stay in a bikini out during these peak hours with no coverage. So as much as possible, you want to wear clothes. That's even better than sunscreen. You want to teach children sun protection early. These are my kids, and they've known since they were born that they can't go outside without swim shirts and sun hats. And in fact, one year we were swimming in an indoor pool, and they're like, Mommy, you didn't put our sun shirts on. So it's good to teach them early, because as you've heard, it's really important to educate them when they're young. Avoid tanning salons. I've talked a bit about this already, but Some of these newer tanning salon lamps emit doses of ultraviolet radiation that are 12 times more powerful than that of the sun. Again, exposure can increase your risk for melanoma by 75%. It is recognized by the FDA as a human carcinogen. I mentioned like cigarette smoking. So a safer option for people that still like to look tan are sunless tanners. Vitamin D controversy, beyond the scope of this discussion, but I think it is sufficient to have a diet with supplements that includes vitamin D. I think that there's a lot of press out there that you need unprotected sun exposure to get vitamin D, which I firmly disagree with. I think eating a healthy diet with a vitamin D supplement is a better option. Examine your skin regularly, and most importantly, if you notice any changes, see a dermatologist promptly. I just want to get the message across that skin cancer is so common, but thankfully a good proportion of it is preventable and curable. And I just want to thank the Skin Cancer Foundation, who provided me with a lot of the clinical photos and some of the literature for this discussion. So thank you for your attention.